Welcome back guys. Now in this video, let's discuss about prolactin. See, we all know prolactin is the hormone which is responsible for the milk production. So first you have to tell me from where this prolactin is coming, from the anterior pituitary, from which cells, lactotrophs. Now question is, what are the conditions in which the prolactin level increases? Every student knows that it's a dopamine which is going to decrease the prolactin. Dopamine decreases the prolactin. Yes, dopamine also called as a prolactin inhibitory factor. It is the one which is decreasing the prolactin, everyone knows. But what are the conditions in which the prolactin level increases? During pregnancy, during lactation, during sleep and during the release of TRH. So here I am showing you the 4 conditions. Guys, look carefully here. So estrogens, pregnancy, lactation, sleep and TRH. The TRH is the most important point. Okay, TRH. So these are the conditions where the prolactin levels increases. Okay, TRH is very important for your exam. Now you might be thinking, sir, what exactly is this hypothyroidism and what is the role of a TRH in the release of prolactin? Let me tell you. Students, let's look at here. Imagine here is the hypothalamus. Down to the hypothalamus, what is this? Pituitary gland. And here is the thyroid gland, let's say. Okay, here is the thyroid gland. Now, imagine there is a condition where the thyroid gland is getting damaged. The thyroid gland is getting autoimmune destruction of thyroid gland. So this condition is called as a Hashimoto's thyroiditis. There is a condition called as Hashimoto's thyroiditis, where there is autoimmune destruction of the thyroid gland, especially by the lymphocytes. The lymphocytes will come and they will infiltrate the thyroid gland and cause the destruction of the thyroid gland. So now you tell me, where is the problem? The problem is in the thyroid gland. But what is normal? Let me tell you what is normal. Normally, yeah, there is a nucleus in the hypothalamus. The nucleus will produce a hormone called as a TRH. The TRH will come and act on the thyrotropes in the anterior pituitary. Now the thyrotropes will produce the TSH, and TSH will stimulate the thyroid glands to release T3 and T4. And this T3 and T4, what they will do? The T3 and T4, once they are produced, they will give the negative feedback. What they are giving? They are giving the negative feedback for the hypothalamus and the pituitary gland, not to release the TRH and TSH. Negative feedback. Now, what is happening in the Hashimoto's? Now look, what is the pathology? Okay, in Hashimoto's, where is the problem? The problem is within the thyroid gland. So can I call it as a primary, means the problem within the gland, primary hypothyroidism. Primary hypothyroidism means as a thyroid gland is being destroyed, what do you think will happen to the T3, T4 hormone production? It is not there. There is no more T3, T4. So T3, T4 is not there. Without T3, T4, do you think this negative feedback will work? No, there is no negative feedback now. There is no negative feedback. Without negative feedback, what do you think will happen to these TRH levels? TRH levels are going to be more. So in a patient with this hypothyroidism, especially primary hypothyroidism, it's not the secondary, guys, remember, primary. In a patient with a primary hypothyroidism, what is happening to the TRH levels? Increases. Now this TRH, it can stimulate the lactotroph. What it can do? It can stimulate the lactotroph to release prolactin. So that's the reason why in a patient who is having hypothyroidism, in a female who is having hypothyroidism, her prolactin levels will be more, and that can lead to galactorrhea. Okay. So always remember what are the conditions where the prolactin levels are going to be increased and the conditions where the prolactin levels are decreased. Every student knows dopamine decreases the prolactin, but you should know it's a TRH which is having a capacity to increase the prolactin. Okay. So pregnancy, estrogens, lactation, sleep and TRH or primary hypothyroidism, you can say, can increase the prolactin levels. Next, what this prolactin is doing? See, this is also a question which was tested in the exams. See, for the production of the breast, I should say for the development of the breast. Okay. See, for the development of the breast, there is mammogenesis. What is required? Estrogens are required. Okay. Next, progesterone is also required. And prolactin also. So yes, prolactin helps in the breast development. That is the reason why in a male who is having hyperprolactinemia or high levels of prolactin, that can lead to breast development in the males, that is gynecomastia. Hyperprolactinemia can lead to gynecomastia. True. Next, yes, prolactin helps in breast development. Next, lactogenesis. Lactogenesis means what? Once there is breast, the breast should produce the milk. So that is lactogenesis. Again, lactogenesis require prolactin. Okay, now milk is produced. Now once the milk is produced, the milk should come out. Okay, the milk should come out when the baby is sucking, right? That is called as a galactokinesis. Galacto means milk, kinesis means movement, means milk ejection. For milk ejection, it is not the prolactin which is required, that's the oxytocin. Oxytocin is required. Now, next thing is, once the milk is coming out, on one side the baby is sucking and the milk is coming out, and at the same time again new milk production has already begun. For the maintenance, again new milk production has started. So that is called as a galacto, means milk, poiesis means again new production. Okay, that is again because of prolactin. Okay, that is again because of prolactin. So you can see prolactin here, here as well as here. There are three places where you can see the prolactin. That is helping in mammogenesis as well as lactogenesis as well as galactopoiesis. Okay, in all these places prolactin is required. So these are the functions of the prolactin, and in the exam they will ask you the order or sequence. What is first and what is last. So it's always mammogenesis, lactogenesis, galactokinesis and last galactopoiesis. Okay, galactopoiesis is nothing but the maintenance. Okay, maintenance. Now, let's say the problem with the prolactin. See, prolactinomas, it's a clinical condition. Prolactinoma means a tumor of what? It's a tumor of lactotrophs. One of the most common anterior pituitary tumor. Prolactinoma, it's what? It's a tumor of lactotroph. Okay, it's a tumor of a lactotroph. Now, what happens if a patient is having prolactinoma or a tumor of this anterior pituitary? Guys, look at here in this diagram. You can see here, these are the eyeballs, and back to the eyeballs, what is this nerve coming? This is the optic nerve. And both the optic nerves, they will cross in an area called as the optic chiasm. This area is called as the optic chiasm. And just look here, where this prolactinoma is happening. The prolactinoma is happening just back to the optic chiasm. Because what is the gland that is situating here? Back to the optic chiasm, there is pituitary gland. Now there is a tumor to the pituitary gland, called as a prolactinoma. So now, my question is, this prolactinoma, it is compressing which structure? Optic chiasm. So definitely there will be some problem with the vision, because the vision is going to be affected when the optic chiasm or this visual pathway, when it is getting affected, definitely there will be some kind of a visual problem. So what will happen? So right, see these prolactinomas, they will compress the optic chiasm. When they are compressing the optic chiasm, they will cause visual disturbance, and that is called as bitemporal hemianopsia or hemianopia, you can say. So in bitemporal hemianopsia, what happens? See the temporal vision, you can see, let's say this is the whole visual field. Now, in both the eyes, it is the temporal vision that is getting affected. Okay, whenever there is compression of the optic chiasm, it is the temporal vision which is getting affected. The nasal vision, okay, the nasal vision or the central vision is okay, but the temporal vision is getting affected. So this is called as a bitemporal hemianopsia. So with this, what we have completed? We have completed the clinical part also. Now, how to treat such prolactinomas? See, in prolactinomas, there is going to be high level of prolactin, right? See, in a patient who is suffering with prolactinoma, it's a tumor of lactotrophs, there is definitely going to be high levels of prolactin. Okay, so this high level of prolactin, it will unnecessarily cause galactorrhea. Okay, prolactin is an anti-reproductive hormone, guys. So prolactin, it will try to decrease the GnRH, FSH levels, LH levels, decreasing the estrogen, progesterone levels. So always remember, prolactin is anti-reproductive. It decreases the reproductive hormones, it decreases the libido. So it's causing a lot of unnecessary problems, right? So as a doctor, what we have to do? We have to decrease this prolactin. So how can we decrease this prolactin? By using drugs like dopamine. Have I already taught you who decreases the prolactin? Dopamine or prolactin inhibitory factor. So for this treatment, see the drugs decreasing the prolactin. What are the drugs which are decreasing the prolactin? Like dopamine. Dopamine decreases the prolactin. Or levodopa, L-dopa. In your pharmacology, you will study the levodopa. If you take levodopa, it will cross the blood-brain barrier, it will enter into the brain and it's getting converted into dopamine. So dopamine or levodopa, both are same things. Okay. Next, so there are two drugs like cabergoline and bromocriptine. I have already explained you this in the basics topic. So the cabergoline, bromocriptine, what exactly are they? They are nothing but dopamine receptor agonists. They act like dopamine. They are dopamine-like drugs. So all these drugs are nothing but dopamine. they can all decrease your prolactin levels. So in a patient who is suffering with hyperprolactinemia because of any reason, maybe because of prolactinoma or some other reason, if a patient is having hyperprolactinemia, high levels of prolactin, the drug that you have to use is dopamine or dopamine-like drugs called as a cabergoline or bromocriptine. Now, one more important point regarding dopamine is, see, the dopamine in low doses, it acts like what? It acts like a vasodilator, especially causing the vasodilation of the renal blood vessels. So that's why it is the drug of choice for shock with oliguria. If a patient is having shock, okay, there will be definitely kidney failure, right? Okay, whenever the patient is having shock, there is a decreased renal blood flow, so there will be kidney failure. So if a patient is having shock with oliguria, in order to maintain the kidney function, in order to supply the blood to the kidneys, we can use dopamine. Why? Dopamine in low doses, it acts like a vasodilator, especially causing the vasodilation of the renal blood vessels, making sure the blood flow will happen to the kidneys and there won't be any kidney failure. Okay, so yes, dopamine is the drug of choice for a patient who is in shock with the oliguria. With oliguria is important. Okay, so with this successfully what we have completed the topic of prolactin. Hope the video is helpful. Thank you.